All right, we're on our last category of dysrhythmias, and that is ventricular. I know you feel sad that we're coming to the last category, but this is it. All right, so we're going to start by talking about PVCs, which I'm sure you've seen people all over the hospital with PVCs, and it's time for us to really understand what they are. So it's ectopy, and remember that reasons people get ectopy are low on oxygen, electrolytes out of whack, stretch. These would be the three big reasons. Well, if we have a cell down in the ventricles somewhere, it's just not even on the conduction system, and it's only supposed to contract, but it has become irritated, and it's feeling fizzy, and it wants to just explode with electricity. It is extremely susceptible to low oxygen down in the ventricles. So especially left ventricle, it's very muscular, consumes a lot of oxygen for contracting in the left ventricle. So when people have coronary artery disease, if they're in a low flow state, if they have oxygenation problems because of lung issues, breathing issues, whatever, but especially coronary artery disease, and they have a lack of oxygen to especially the left ventricle, they can really start getting some ventricular ectopy, like throwing off some premature ventricular complexes, PVCs. So if this cell fires off electricity, what would the complex look like? Well, we're not anywhere near the atria, so it's not going to make any kind of P wave at all. It's just going to make a QRS. And down here, the electricity is going to travel in every direction. It's going to go cell to cell to cell to cell to cell to cell to cell. Some of it might jump on and go whoosh onto the bundle branches. Others are just traveling cell to cell to cell to cell to cell. Some of it's already contracting, while part of the electricity is still traveling across the septum over to the right ventricle. Whoosh. Some of it goes on this bundle branch system, goes to Purkinje fibers, cell to cell to cell. It takes a long time, so the complex is going to be very wide. The electricity goes a lot of different directions, so the shape will be bizarre. A lot of times it has notches in it. So wide and bizarre, it's typical that the T wave will go in the opposite deflection from the bulk of the QRS. So we expect a PVC to be, oh, that's not going to do at all. Let's go back to our friend purple. We expect it to be wide and bizarre with maybe like a notch or something, and T in the opposite deflection. No P wave. So this would be like a typical looking PVC. But also it could just be like slanty maybe, and then go like way below the line, or it could go above and below the line, and then the T wave could be on top. Like it could be anything, but it's going to be QRS greater than 0.12 for sure, and probably a lot more than 0.12, and that's how we know that it came from the ventricles. The width of the QRS and the bizarre shape and the T wave and the opposite deflection. So part of the fact that it's depolarizing in one direction and repolarizing in the other is part of the clue about where the location of the cell is. And then the wideness, and then the bizarre shape with the notches and stuff. So all of those are clues. This is a very ventricular looking beat. So we say it looks ventricular because we learned what does a junctional beat look like. Well, this is what a ventricular beat looks like. So this is a PVC. In order to be a PVC, premature, it has to jump in early, because normally if your sinus beats are coming down, then this cell won't get a chance to fire if it's being depolarized over and over again by every sinus beat. So the only way it's going to get one of these in on your rhythm strip is if it can jump in early, right? So we're going to see a PVC kind of mushed up against another sinus beat. So you'll just be going along in your sinus rhythm, and then the PVC is going to jump in here early, little gap after it, and then you'll go back into your sinus rhythm. So when you see a couple, the second beat is always the premature complex. If the second beat in the couple just kind of looks like another sinusy beat with a nice little P in front of it, then it came from your atria. It's a PAC. If the second beat in the couple doesn't have any P, just a flat line and a QRS, then it's probably a PJC. If the second beat in the couple is wide and bizarre and gigantic, then it's a PVC. So when we look for those couples with a little gap after it, that's a premature beat. The second beat is the premature beat because it's scrunched up against the one ahead of it. And we will look at some strips in class. So that's a PVC. What if this cell right here got really fast, got fast enough that it could jump in once and then just keep going and then just take over the entire rhythm? What if you had nothing but a whole line of PVCs? That's VTAC. So if this cell got dominant and fast enough where it could just continue to repolarize and beat over and over and over and never allow another sinus beat to get back in, then that's VTAC. So VTAC is an ectopic rhythm. It's dangerous because we don't want to skip your entire conduction system. These big, wide QRSs are not effective. They're not good systole. You don't get good stroke volumes off of them. You don't get any atrial kick out of these guys. And the rates are fast. So they're just going to be wide and bizarre, rapid. They have to be rapid or they couldn't get in and take over. Something weird like that. The T's go in an opposite deflection of the QRS's. Sometimes it's hard to tell which one's a QRS and which is the T. It almost doesn't matter that much. They can be all different shapes, something notchy and weird. They really like, VTAC really likes to go at a rate of 150. That would make these two big boxes apart. Like SVT, VTAC is paroxysmal. Just like anything, it has to jump in is the only way that it could take over. So a lot of times you're going along in sinus rhythm and then it's one PVC that jumps in and then they're in VTAC. But the rate's not as fast as SVT. 150 is very common. 200 is a very fast VTAC. So 150 is very common for VTAC, but it's not as easy to break as SVT. All right, so they're going along at like 150, they're in VTAC. VTAC we always take extremely seriously because it's a ventricular dysrhythmia, and that means it's life-threatening. So we got to run in and do something about it. So let's talk about treatments for VTAC. It really depends on how the patient is doing, but it's always an emergency. So VTAC, I always run. I always at least jog. Okay, so I will run. I will get up and run if I see VTAC. So we got three possibilities. We could have a patient who's totally pulseless, like mostly dead. We have a patient who has a pulse, but they're definitely unstable, like maybe totally unconscious, or they're awake, but they have like crushing chest pain, so definitely very unstable. Or we'd have a patient who is stable. So stable doesn't mean no symptoms. They have symptoms, but they have decent blood pressure, they are not having chest pain, and they are oriented. That's not as common, but I definitely have seen it plenty of times, strangely enough. So, okay, let's start with the first one. Let's say that you have somebody who is no pulse. So you see VTAC, you run down to the room, they look unconscious. So you check on them, so you shake them. Hey, are you okay? No response. before you do anything else, you call the code, because whether they have a pulse or they don't have a pulse, you got to get some people in there to help you at this point, because they have VTAC and they're unresponsive. That's all you need to know. Okay, so people are coming. You check for a pulse. You do not feel a pulse. You start chest compressions. Okay. People show up with a crash cart. We shock them. Do we need to make sure we don't shock them on a T wave? No, because they can't get any worse. They don't have a pulse. So no pulse, defibrillate. Okay, that's one possibility. Second possibility, you see VTAC on the monitor, you run in the room. Let's say the patient appears to be unconscious. You shake them. Hey, are you okay? And they're like, Call for help, because you already know this is a terrible situation. Call for help. Check for a pulse. Are they going to have one? Yes, they just groaned. They have a pulse. So you feel it. They have a pulse. Okay, you don't need to do chest compressions. I would just keep feeling it. So this is honestly what I do. I stand there and I continue to feel the pulse. Somebody else is going to show up and I'll say, let's say, what can I do? And I'll say, let's put them on continuous vital signs. Let's get them on oxygen. Let's move this stuff out of the way. They're coming in with the crash cart. I just keep feeling the pulse, because a lot of times people go from VTAC to VFib. That's very common in a code. So as soon as I don't feel this pulse anymore, I can immediately start chest compressions on them. So a lot of times I just stand there feeling it until I'm like, not sure if I can feel it anymore, start my chest compressions. Okay, and also I've shown up to rooms before with the crash cart, and I look at a patient in the bed who is obviously dead, and people are standing in the room waiting for us to arrive, and I say, why isn't anybody doing any chest compressions? And they say, oh, he has a pulse. And I'll be like, I'll bet you $1 million that he does not have a pulse. And they'll be like, oh, he did have a pulse when we called for the code. Okay, so he has a pulse, but I got off track for a second. He does have a pulse, but he's very unstable. Okay, and the people are there with the crash cart and everything. If he has a pulse, it is possible to make him worse by sending him into VFib. So we will synchronize and shock. That's called cardioversion. Okay, so yes, pulse, but unstable. Cardioversion. Now we go to the third possibility. They're in VTAC, you go in the room, the patient is conscious. You say, hey, how are you doing? And they go, oh, I don't really feel that good. I can really feel my heart beating hard. And I feel a little short of breath. You say, are you having any chest pain? And they go, no. And you say, okay, well, let me check your vital signs. I'm gonna get some of my friends in here and we're gonna take a look at you. And then they actually have an okay blood pressure. They're not having any chest pain. You have some people come in to support you. We got a doctor coming in and we're trying to decide, should we cardiovert them or should we give a medication? So when somebody is oriented, they have blood pressure, they're not having chest pain, then we're going to call that person stable. But VTAC is serious business, so a lot of times physician will opt to just cardiovert them anyway. So option one, so let's call this person stable. And remember, stable does not mean asymptomatic. They can still have symptoms, but be stable. There's certain symptoms that you decide make somebody unstable, and those things are like chest pain, change in LOC, including like loss of consciousness or just becoming confused. So loss of blood pressure. Okay, so stable, you have a couple options. Option one, controlled cardioversion. where we say, well, I think we're going to need to, you've gone into a different heart rhythm, and I think that's the pounding that you feel, and I think that we're going to need to convert you back to a normal heart rhythm, and doctor's going to talk to you about that, and I'll give you some medication before we do that procedure. So we're going to do a nice controlled cardioversion and get the patient's permission. If at any time they become unstable, then we go into ACLS protocol and it becomes like a code situation. But we could do a controlled cardioversion, or if we're right there and we can quickly do it, doctor might say, let's try a medication on him first. So we're going to use an antidysrhythmic to convert somebody out of a rhythm. And the drug that we're probably going to use is amiodarone. That is a rhythm-changing drug, an antidysrhythmic. So we have a protocol for that where we'll give a bolus and start a drip and see if that will change him out. But we have a low tolerance for just letting people lay in a bed and VTAC, so we might want to go with this one. We'll see though. And then there always is this other possibility, which is that people might have a bundle branch block, which is what we'll look at in just like 1 second. And then they are really an SVT, but it looks like VTAC. And that's why they're so stable. In which case, what can we do for people who are an SVT and they're pretty stable? We could try a vagal maneuver and then give them adenosine. So there is a time when sometimes we try adenosine on a very stable, more like they sure are awfully stable for just sitting there in continuous VTAC, where sometimes the doctor will like, let's just give him a little shot of adenosine and see if it breaks it, because adenosine only works on SVT. So if it works, then it was not VTAC, it was SVT. So every now and then we have somebody who's super stable and we're all just like, look at him. They seem awfully relaxed in VTAC. The doc will say, why don't we just give him a little adenosine? And it's like a test to see if it really is SVT with a wide QRS, because it's really hard to tell the difference. And so that's a little bit advanced, but I just thought I'd throw it in there for some of you that maybe already work in areas like this and have seen that kind of stuff. If that was confusing, you can just excise that from your memory. So here are your three options. No pulse, call the code, shock them, just defibrillate them. They have a pulse but they're unstable, synchronize and then shock them. That's cardioversion. If they're stable, you could choose to go with a medication like amiodarone, or you could just go ahead and do a cardioversion anyway. All right, now we're down to the big mama, and that is VFib. VFib is kind of like AFib in that now you have multiple ectopic foci, but now they're in the ventricles. That's no good. So they're all firing, and it's like an electrical storm, but it's in the ventricles, and they're just vibrating. So there is no contraction. There is no pulse. There is no cardiac output. There is no stroke volume at all. Nobody's conscious ever. Nobody has a pulse ever. So that's one way that you know that it's not just artifact. Because a thing that can look like VFib, because here's VFib. Just like a bunch of weirdness on the line, just some scribbles. VFib is just a scribbly line. But the other thing that could mimic VFib is artifact, which is just like somebody's electrode getting stuck partially on their hair, and then they're trying to like walk to the bathroom and it's moving around on their hair and on their shirt, and you get some scribbly stuff. Or it's fallen off and it's sticking on their bed rail, one electrode, and they're moving in the bed, and it looks like VFib. But if you go in the bed, if you go in their room and the person is awake, then they are not in VFib. because no one ever has a pulse and no one is ever awake in VFib. So VFib is just a scribbly line. You can have VFib with a little bit more amplitude, like this, or you can have VFib that is practically a systole, a flat line. This person has more chance of surviving than this person, and probably your intuition already told you that. There's one treatment for VFib, and that is defib. That is the only treatment that we really have. Well, you start some chest compressions. So if somebody's in VFib, you run down, you call the code, you start the chest compressions. When people arrive, you defibrillate them. That's all there is to do. You shock them, and then we start the ACLS algorithm of shocks and epinephrine. The epi in the algorithm is just to try to bring blood to the area so that we can get a little bit more amplitude so that when we shock, maybe an organized rhythm can emerge. So maybe we can get a little bit more blood to the sinus node so that when we wipe them out to asystole, maybe the sinus node can come out with some kind of rhythm. Wipe these out. When somebody's in a very flat VFib, there's very low chance that we're going to be able to get them back with defibrillation. So in fact, one of the things that we do, especially in pre-hospital situation, is if it looks really flat, sometimes we break with ACLS protocol and we do like a couple cycles of super aggressive chest compressions just to try to get some blood back to the myocardium before we shock them, because we know that this is going to be unsuccessful defibrillation. This, we have a much better chance. The most important thing you could do if you're the first person on the scene is to immediately begin chest compressions and make them good. And don't stop. Don't pause. Don't get distracted. Do them the whole time up until the point that somebody defibrillates. Because the better the blood flow up until the moment we shock, the more likely that we're going to get them back with one shock or at all. So that is VFib. There's only one treatment for it. But really we could say two, because the chest compressions are very, very important. And then when we're in the ACLS protocol, we do have other medications to give. And so we will look at the algorithm for VFib. But it all starts with defibrillation. All right. Let's talk about ventricular escape rhythm. So those were ectopies, but let's talk about an escape dysrhythmia. So not an ectopy. So you have a cell that is probably on a Purkinje fiber. Because ectopies are cells that are not even on the conduction system. But escape is probably a cell that is on the conduction system. So it's probably like here on a Purkinje fiber somewhere, or on a bundle branch. Well, let's say it's like right here. And for some reason, I feel bad for you, that your sinus node has failed, your AV node has failed, your bundle branches, you're all the way down. Nothing has ever come down for a heartbeat. And finally, it's like, hey guys, who among us can come up with a heartbeat for our person? And among all the pacemaking cells down here that have any ability, any automaticity at all, this cell has the highest intrinsic rate. Let's say that it's not very good, it's like 31. And so it is going to begin a ventricular escape rhythm. There will not be any P's because there's no atrial activity occurring at all. It will look like ventricular beats, so wide and bizarre with the T in opposite deflection, and just that's what there's going to be on the line. So wide and bizarre at a rate of 31. there's our ventricular escape rhythm. When you see it, don't say it's VTAC because it's not tachycardia. It's slow and ventricular with no P's. That's ventricular escape rhythm. Now, we would never try to wipe it out with cardioversion or drugs or anything because there's nothing under this but asystole. This is the very last gasp of your conduction system. So we would just be like, what the heck happened to the rest of your conduction system? So probably what we would do for this person, can you guess? We would probably put them on a pacemaker. And unless they have something that's reversible in the near future, they're probably going to get a permanent pacemaker. But my guess is they had a massive MI to get in this sorry state right here. So that is ventricular escape rhythm. Occasionally we have like a big code, and then this is what they come back into. A third degree block with a ventricular escape or ventricular escape rhythm is not very good. They have hardly any myocardium functioning. So then on the defibrillator, we turn it to pacemaker mode, and we're just continue to pace them through the pads that we use to defibrillate them with, and see if we can like get some function back to the heart. And the very last thing that we're going to do is talk about a bundle branch block. So it gets kind of stuck onto the end of the ventricular rhythms. A bundle branch block is not a rhythm, it's just a problem that people have with their bundle branches. A lot of people have this problem. So it just means that somewhere in your bundle branches, and remember that even though I just draw one bundle branch on the left side, that really you have two fascicles to your bundle branch. You have, because the left ventricle is big, you have one fascicle that comes high in the front, and in the back, so I'll do a dotted line, you have one fascicle that goes low and in the back. So you have an anterior superior and a posterior inferior. So you can have some damage to any of these three fascicles of your bundle branches. You might just have a place where like the bridge is out a little bit. So just to make it easier to see, we'll just do a right and a left. So either on your right or your left, and it could be on either fascicle of your left, you have an area where like the bridge is out. You have damage to your bundle branch. So when the electricity comes down and hits that, right here, it has to go cell to cell to cell to cell to cell. And then, so there's a little delay in this area. And when it gets off course, some of it just starts going cell to cell, some of it gets back on. So your QRS, you still have a P, you still have a PR interval. Your QRS started out good, but then maybe you get a little notch right here, and it was a little bit wide, and then you get your T wave. So it looks okay. But when you go to measure, so you're like, okay, that's good. And then when you go to measure, you're like, oh, QRS, it's 0.12 or greater. It's a little bit too wide. So it took a little bit too long to get down the bundle branch system. There's some delay or some damage in the bundle branch system. Some bundle branch blocks are just a little bit hard to even notice until you do the measurement. Some are very obvious, where they start getting wide with notches. It almost starts looking ventricular. But it's not, because they have a P, a QRS, and a T. So when a rhythm has one P for every QRS and the P's are all the same, then that's sinus rhythm. But then when you do your three measurements and the QRS is too wide, you're going to say sinus rhythm with a bundle branch block. And the bundle branch block is just really a measurement that you found when you did your three measurements. And could people have sinus rhythm with a first degree AV block and a bundle branch block? You bet they could. So you could go to measure the PR interval and it's too long, and then you have to say with first degree AV block, and then you go to measure their QRS and you're like, oh, for Pete's sakes, it's 0.14. And then you have to say with, also with a bundle branch block. Yes, people have, they love to have multiple issues all the time. So that's a bundle branch block. It's always with. Their whole rhythm isn't bundle branch block. It's like a thing they also have, just like first degree block. That's it. Oh my gosh, that's a lot. Okay, that is all your categories. So, you know, take it like one category at a time. You can always go back and listen, and then bring your questions to class, and we will look at strips, and we will practice them together. And remember, you don't need to be an expert. This is just trying to get an idea of the different dysrhythmias. So I hope that this was helpful, and I will see you guys in person or maybe remotely soon.